And share. Okay, so welcome everybody to our first exposure to the field, and our first category will be specialty pharmacy, and we have Dr. Anguiano with us today to talk about her work and how she got to where she is today. So first we have a few announcements. First off, Melody, professional chair, has an event for us. It is the pre-talk medication safety workshop on Monday, November 22nd at 4:45 p.m. She's looking for about 4 to 5 students that can help create a presentation on medication safety and help host an interactive workshop for the pre-talk after school program. So if you're interested, she didn't drop a link, but I believe she here right now? No, but yeah, we can provide that link so you can get all signed up, or you can contact her personally. Oh, she's here. But and then Eileen.
Hi everyone, can you hear me?
Yes.
Hi. So APA has our Pocky fundraiser and it's live now. You can buy chocolate, strawberry, or cookies and cream flavors for $2.50 each, or 3 bags for $6. So that's a really good deal. The last day to order these will be November 11th at 11:59, and I will drop the order form for you guys. Please consider buying some. Thank you.
Thanks, Eileen. And then for everyone that's trying to get credit, we'll show you the QR codes for the attendance and everything after the presentation. So without further ado, let's introduce Dr. Rebecca Anguiano, PharmD, BCPS, BCACP, a mouthful, and I'll let her do her introduction. So let me stop sharing. And you should have the ability to share.
Great, let me share my slides right now. Just take me 1 minute to get set up here. Great. And let me switch. There we go. All right. So first and foremost, I want to thank Justin and the e-board for inviting me here to talk today to you about specialty pharmacy and careers in specialty pharmacies, and a little bit about how I got to where I am today. Before I go forward, is the visual okay and is the audio okay? Thumbs up, excellent. All right, so specialty pharmacy is something that I really love talking about. Myself, not as much, but definitely specialty pharmacy. I think it's probably one of the most interesting and versatile career paths that you can take in pharmacy today. I'm sure in 10 years it may change. There's probably going to be something new. But right now, this is probably one of the most robust areas in specialty pharmacy practice. So really happy to be here to talk to you about it today. So again, here's my information. I'll just save talking about myself until later on. We'll just talk about specialty pharmacy first. So a little bit of an overview of specialty pharmacy. It's kind of an interesting area how it developed. It really began in the late 80s, possibly even before that. It depends on who you ask, but it was related to the introduction of these really high cost, potentially life-saving or life-prolonging specialized therapies to treat rare or complicated diseases. A lot of these therapies were treatments for cancer, some of the first MS related disease modifying therapies like interferon, for instance, or mitoxantrone, hemophilia, and the list goes on and on, even transplant at the time. So the problem with these drugs is, at least in terms of like 1980s costs, they were incredibly expensive, and a lot of them had some logistical issues in terms of cold chain management, billing, getting reimbursed for the drug. And given the fact that they were for disease states that were kind of less common, the patient volume at a lot of hospitals and health systems really wasn't high enough for them to be able to justify taking on the management of these patients. And it's kind of interesting because there was a small sort of niche group of entrepreneurial pharmacists that identified this need. And they developed this pharmacy model called a specialty pharmacy that really focused on providing this targeted care for patients with these complex or rare or orphan diseases. So these niche businesses were offered by, a small number of pharmacies, small number of pharmacists, but they provided these services nationally. And that's kind of one of the more traditional models of specialty pharmacy. It could have been local, but more often national. So they were able to provide services to do the paperwork, to do the billing, to offer cold chain shipping through economies of scale. And then, of course, as you've probably seen over the last 3 to 4 decades, specialty pharmacy has actually evolved into one of the fastest growing sectors in pharmacy, just in general. And it's not really necessarily exclusive to orphan or rare disease, complex diseases anymore either. There are even more therapies that are potentially included in the specialty pharmacy realm that may not necessarily meet like that older definition of specialty pharmacy. So what is a specialty medication? Again, it kind of depends on who you ask. There's a lot of organizations that have kind of taken a stab at creating a definition of what a specialty drug is. Medicare, for instance, decided to say that anything that costs over $600 per patient per month is going to be categorized as a specialty medication. And as you guys know, there's a lot of drugs that may exceed that $600 threshold that don't necessarily meet specialty pharmacy criteria, but Medicare kind of just loosely defines any drug over $600 as a specialty drug. But the more commonly accepted definition of a specialty medication is more so based on characteristics of the drug. And that's also very consistent with, accreditation bodies. When you're doing management of specialty medications, they'll include medications that meet certain criteria or have certain characteristics. Don't worry, I'll talk about accreditation again a little bit later on, so you know what I mean by that. But so some of the overall characteristics of specialty medications and how we define specialty drugs are, of course, high cost. And I'm not talking about $600 a month. I'm talking about like drugs that cost upwards of $100,000 a year. Or there's one drug that costs $2 million per dose. It's like a one-time dose thing though, but still, it's very high cost drug. Often they're used to treat rare or orphan diseases, but it's not an exclusive category. So disease states that may be more complex in nature may also be included here too. So a lot of cancer is probably the biggest area of growth in specialty pharmacy right now. And we all know that cancer in general is not rare, and even certain types of cancer are not necessarily rare. These drugs may also require special handling. And what I mean by that is there may be special requirements in terms of dispensing the drug, in terms of delivering it to the patient, like it may require cold chain shipping. There may be certain toxicities associated with handling the medication, like teratogenic toxicity is a potential for some medications. So there's certain ways you have to handle those medications. They may also require special claims processing. So our business model is pretty much based off of doing prior authorizations. Pretty much every single specialty drug is going to require a prior authorization. And it kind of used to be that prior auths were more associated with specialty drugs, but now if you guys work in retail or pretty much any pharmacy setting, you know that prior authorizations are actually somewhat ubiquitous now. And even inhaler therapy, hypertension therapy, I mean, everything is requiring RPA these days. But they may also have specific claims processing requirements or step therapy involved as well. Also includes infused or self-injectable drugs, so basically non-oral medications. Although again, that's an area we're seeing a lot of change in, and especially in oncology, we're seeing a huge shift towards oral therapies over infused or injectable therapies. And then it could be oral drugs for specialized disease states, or it may just be medications that require intensive patient management. And oftentimes when these drugs are categorized, they may have to meet at least 3 or more of these criteria. But again, that's not always tried and true either. In fact, sometimes it really depends on, I have Sorry, there we go. Got some fun animations in here. Sometimes it just depends on what the payer says. They may actually just categorize a medication as specialty pharmacy when it may not necessarily meet the specialty medication criteria. Examples of those are PCSK9 inhibitors for hyperlipidemia. So if you would look at those medications and run it through this like an algorithm based on specialty characteristics, those may not necessarily meet criteria for specialty medications, but a lot of payers classify them as a specialty therapy. Some of the CGRP inhibitors for migraine therapies as well, Veltessa for hyperkalemia. These are all drugs that kind of meet not necessarily specialty medication, but not necessarily traditional medication. So payers just decide to categorize them as specialty pharmacy. And we'll talk about some reasons for why they do that a little bit later on. So what are some specialty drugs? Well, this is by no means a comprehensive list, but here are some examples of some specialty medications that you may have seen. And some of these you may have seen in practice, some you may have learned about in some of your classes, and some of you may work in a specialty pharmacy or be volunteering at specialty pharmacies. So you may be familiar with some of these. The big area that we treat is the inflammatory conditions. And by that, I mean like connective tissue diseases, other inflammatory like rheumatoid arthritis, Crohn's disease, ulcerative colitis, the list goes on and on, ankylosing spondylitis. They all kind of meet this group of inflammatory diseases, and a lot of drugs that we dispense for them are biologic drug therapies. Multiple sclerosis, a lot of injectable and oral therapies there, oncology, hepatitis C virus has long been a specialty pharmacy type disease state. HIV, growth hormone deficiency, cystic fibrosis, pulmonary arterial hypertension, which is an area that I contribute to quite a bit, and I'll talk a little bit about that later on. Hemophilia and infertility as well. What do specialty drugs look like? Well, here's a couple of examples of medications that may be dispensed and managed by specialty pharmacies. So I'm not going to go into great detail on here. I just wanted to show you a couple of examples. Like the Humira pen, that's probably the highest volume drug that we dispense is Humira. It's a self-injectable. It comes in a prefilled syringe or an auto injector, as is displayed here in the center of the page. This is medication that's given either every 2 weeks or once weekly, depending on the indication and the disease severity of the patient. And it's also approved for a large variety of inflammatory disease conditions. So in this medication that needs to be refrigerated in storage and then can be held at room temperature for a certain period of time. But with this medication, again, it's high cost, it's self-injectable, it's used to treat inflammatory disease, which includes a lot of rare or complicated disease states, generally requires a prior authorization, and it has certain patient management requirements. And some of those might include infection monitoring, because this is a drug that can suppress your immune system and make you more prone to or more susceptible to certain types of infections. Patients have to be trained on how to administer the drug. So they have to know how to use this device and how to actually give themselves the injection, which can be a barrier for some patients. And it can be very costly. So even if a prior authorization is put in place, doesn't mean it's always going to be affordable to the patients, because there are certain measures that payers put in place to offset their costs. And sometimes that's putting the burden on the patients. So sometimes copays and coinsurance may preclude patients from obtaining these medications. So just an example there. Now, I think one of the ways to best characterize specialty medications, although it's not a good way, but it's a very common way, is by their cost. So again, specialty drugs are incredibly expensive, and I wanted to include this just so you can kind of see the magnitude of exactly how much cost specialty drugs contribute to overall drug spending. So you can see here, orphan drugs and specialty medications, or drugs that are classified as specialty drugs, continue to contribute an increasing amount of the overall drug cost on an ongoing basis. So you can see here in 2019, specialty drugs accounted for 47%, I should say they rose by 47%, and the overall spending share for orphan drugs rose from 6% to 11%. So it's a huge contribution to overall drug spending in the United States. So basically about half of the overall drug spend. To put that into perspective, only about 1 to 2% of all prescriptions written in the United States are for specialty medications. So they cumulatively account for roughly 2% of prescriptions written, but close to half of overall drug cost or drug spending. So I think that that's something really important to keep in mind and something to consider, when you're managing specialty medications. This is probably the biggest reason why payers place such big restrictions on specialty medications and why there's so much burden related to access and cost of these drugs. It's because of how much they cost. They're obscenely expensive. All right, now I realize this is really hard to see, and I apologize for that. I always caution my students and residents against including slides that are really difficult to read, but I wanted to just include this to give you an example of what some of the most expensive drugs look like. So this is for a 30-day prescription so basically a one fill for each of these medications. And you can see some of the most expensive ones on here are for inflammatory diseases, for MS, for GI related disorders, for enzyme related deficiencies, and also for cancer. There's quite a few medications for cancer on here as well. The top one being Zokinvy, which is $86,000 a year for a month's supply. So just something to keep in mind. A lot of these are also for rare diseases as well, like Myeleptis for a rare disease, Cinryze is for a rare disease as well. Okay, so if you ever thought that you can ignore specialty pharmacy, think again. It's only getting bigger, and there's a couple of reasons for that. I think that the specialty pharmacy model is kind of taking over how we practice pharmacy in general, in my opinion, even in the retail setting. I think that a lot of the practices that we've developed in specialty pharmacy can be applied to other practice settings. But in terms of growth, one of the big reasons why specialty pharmacy is growing so much is because of a very, very robust pipeline of drugs, and it just seems to be increasing. And one of the reasons for this is, of course, this is where the money's at. So this is where a lot of manufacturers are investing time, effort, and money is into specialty drugs, because they may strike out, but if they get a hit, they're really in a good position. So in terms of the specialty pipeline, roughly 50 to 60% of approvals over the last 3 years were designated as specialty medications. So again, think about that. Half of new drug approvals that have been approved by the FDA over the last 3 years have been specialty medications. So that means, and actually in the pipeline, over 6,300 drugs in clinical development are specialty medications. A large majority of those are for targeted treatment towards cancer. And then the second majority, I should say, second most, gosh, can't speak today apparently, are orphan drug designations. So and a big factor in orphan drug development too, I should mention, is the FDA has actually incentivized manufacturers with expedited or accelerated drug approval processes and a prolonged ability to keep a patent in place. So they have like prolonged patent availability for drugs that meet orphan drug criteria. So again, if a manufacturer can develop a drug to treat an orphan disease, they're in a very good position. Now, there's also a huge increase in utilization in specialty medications, and some of the factors that kind of contribute to that are disease prevalence and more common diseases. So one of the big things, like in PAH, for instance, with targeted therapies and treating patients with pulmonary arterial hypertension, there's improved survival. So patients are living longer. We're also identifying better ways to identify and diagnose the patients earlier in the disease process. So we're like improving the ability to diagnose. So we have an aging population associated with that. So that's just one example in a specialty therapeutic category, but that's pretty applicable to a lot of different categories as well. There have also been a lot of changes, and I think this is interesting, a lot of changes in clinical or therapeutic guidelines from national organizations. So an example of that would be in rheumatology, for instance, in treating rheumatoid arthritis, the newer guidelines place greater emphasis on starting patients on biologic drug therapy with Humira, for example, much earlier in the disease process. So in some circumstances, they even say to start with it right out of the gates, depending on the severity of the disease. And older guidelines would require that patients try and fail certain traditional DMARDs first. So we're seeing some changes there. And then, of course, like I kind of already mentioned, we're seeing some medications approved for either untreated or suboptimally treated disorders. So an example there would be, I'll just use Humira again, because that seems to be a good example. They have so many indications. So they just received, or it wasn't just, probably in the last 1 to 2 years, I can't remember what it was, they received or got approved for a new indication of hidradenitis suppurativa. I always say that wrong, or HS, we call it for short. It's painful bumps that are near sweat glands, and they can develop blisters and infections, and it's incredibly painful for patients. But prior to that, there was really no drug therapy options that were highly effective in treating that. And Humira is one of the first to be able to offer a highly effective medication to treat that specific indication. And then there may, for instance, be some super rare types of cancer, for instance, or certain phenotypes of cancer, or I should say genetic polymorphisms associated with certain cancers, where we're developing more targeted therapies for treating those. So again, increased utilization in those areas as well. And then in terms of inflation and brand only, well, there's a pretty profound lack of generic competition in specialty pharmacy, although in some disease states we're kind of seeing changes there. PAH, for example, is one of them. We have a couple of generic drug options now for treating PAH, but there's also a lack of biosimilar penetration until just very recently. I've started to see more payers uptake with the biosimilar agents, but it's been a very slow moving process, unfortunately. So, you know, with branded drugs, they can really set the price wherever they want if there's no competition, and they can continue to increase the price, and it makes it very difficult. So again, that's an area of concentrated focus. A lot of people place a lot of focus on this particular area. Now, the other thing that I wanted to mention, I kind of referred to some payer strategies and how they manage costs. So, of course, these drugs are incredibly expensive, like I've mentioned over and over and over again. And that kind of leads to one of the reasons why we have so many management strategies in place for specialty drugs. I'm not going to go through this in great detail. I just think it's kind of interesting to look at. So there are a lot of different payer strategies that PBMs and insurance companies may implement to manage drug costs. And I think it's worth learning a little bit more about these. The most common ones, I would say, are prior authorization on preferred products. So they may have step therapy associated, where they want you to try a lesser expensive drug for that indication before you're eligible to try the more expensive one. Site of service restrictions may be applicable to clinic administered medications or infusions, like Remicade, for instance, is one where we may see a lot of site of service restrictions. Benefit design, there's a lot of emphasis on that as well with payers. In fact, one of the big issues that we're seeing with specialty medications is, you know, in years past, there used to be just a limited number of tiers. You would have like first tier, second tier, you'd have your generic preferred, your brand preferred. Now, a lot of organizations and insurance companies are creating specialty pharmacy tiers, and then they may have sub tiers within those categories. And for patients that might have their medications in that specialty tier, they may have actually higher cost sharing associated with the specialty pharmacy tier. In fact, I've seen it range anywhere from 5% up to 50% of the cost of the drug, even for generic products. So if you have a patient who, you saw some of the per monthly or per month costs of some of those agents listed before. So if you have a patient that's on a medication that costs $25,000 a month, and their co-insurance or their cost share in the specialty drug tier is 50%, well, not that many patients have access to those kind of resources to be able to afford that kind of medication. So in those circumstances, we do a lot to access whatever kind of available resources are out there for patients. So foundation assistance, copay cards, other kind of charity care organizations, you name it, we try to get funding for it in those circumstances. And then payers tend to prefer to limit the number of specialty pharmacies that they contract with as well. So this is kind of an interesting area and something to note, because it's not only becoming more common, it's also becoming a huge barrier to care with patients. So what we're seeing much more commonly these days is payers or PBMs that are associated with various plans develop specialty pharmacy networks, which are actually separate from pharmacy networks. So they're two different contracts, and they lump specialty drugs in a specialty pharmacy network, and then everything else goes in like a general pharmacy network application. And they may limit the number of specialty pharmacy network applications that they offer, or opportunities that they offer. And that's just one of the ways of limiting who they'll authorize reimbursement for dispensing certain products. So big way to limit their financial impact. In fact, what we see a lot of payers do, unfortunately, is shift specialty medications to their own affiliated specialty pharmacy, which is called steering. You may hear that word from time to time. Steering is when you shift, where you kind of restrict where the drug can be dispensed, and you may restrict it to an affiliated pharmacy that may benefit you. So in terms of specialty pharmacy business models, there's quite a few to think about. It can be chain or retail based. So there's also independent specialty pharmacies, although those are kind of few and far between these days. I think there's only just a handful of operating independent national specialty pharmacy. The large majority of specialty pharmacies are PBM affiliated, possibly plan or payer owned specialty pharmacies. We still do see a handful of those, or affiliated with a large national chain like Walgreens or CVS. Well, CVS is kind of a different entity because that's affiliated with the PBM. But there's also hospital health system based specialty pharmacies, and this is an area of huge growth as well. I work with a large network of health system based or integrated based specialty pharmacies across the nation. And this is an area that's rapidly growing, and a really, really good opportunity, I think, for individuals that want to get involved with specialty pharmacy. This, I think, is also a really interesting slide. It's a little outdated. I couldn't find an updated version. This comes from Drug Channels. It's a really interesting blog. They actually have a lot. They have a daily feed that comes out. If you're really interested in drug distribution and management and cost, I would subscribe to Drug Channels Institute. I would highly encourage it. They have a lot of really interesting information come out. But anyway, so this I wanted to include because it shows the top 15 US pharmacies in terms of share of specialty drug dispensing revenues. So you can see here the blue, which takes up 3/4 of this pie chart, are those PBM or health plan owned specialty pharmacies. That followed by independent, which is, of course, you can see much smaller, retailer chain-based pharmacies, which includes Walmart, Kroger, and Hy-Vee, although I think there have been some mergers within there too. And then wholesaler owned as well, like McKesson and AmerisourceBergen offer their own specialty pharmacies. But the largest portion of specialty drug dispensing revenues comes from, it's led by CVS Health, CVS Specialty, followed by Express Scripts, Walgreens Prime, Optum, and then Humana. I think there have actually been some changes there too, or some mergers there. Anyway, the health system-based specialty pharmacies fall into that everyone else category. So we're somewhere in there, which I think is kind of telling where the specialty prescriptions are going. This I'm not going to speak in too great a detail about because it does get a little bit complicated, but I think it's also important to understand what the concept of vertical integration is, which is highly motivated by ongoing growth in specialty drugs. So essentially, an insurer, a PBM, and a specialty pharmacy align. And any kind of specialty related business, these organizations make an attempt to filter up the specialty prescription through these channels. So an example of that would be, Cigna is the main insurer or the plan. They work with PBM, which is Express Scripts, and their specialty pharmacy is Accreditation. So plans that contract with Cigna and Express Scripts would use Accreditation as their preferred specialty pharmacy. Aetna, CVS Caremark, and CVS Specialty has a very similar relationship. So we're seeing this more and more, this concept of vertical integration. And I think it's something to really keep an eye on in terms of specialty, but also in terms of other medications as well. Now, I mentioned a little bit about specialty pharmacy networks. So this also, it can be very complicated. So I just kind of want to introduce this topic to you. So again, these specialty pharmacy networks tend to be separate from pharmacy in-network status. So, we may be contracted with Aetna, for instance, or to be able to dispense whatever lisinopril prescription we get. But if that same patient is on a specialty medication, we may not have the specialty pharmacy contract to be able to be authorized to dispense their Humira and their lisinopril. We would have to have two separate contracts with the pharmacy network. Most of them are PBM or payer aligned, and many times these PBM or payers, like I just showed you, often have their own specialty pharmacies. So they essentially want to limit the number of pharmacies that are allowed in their network in order to kind of shift or steer prescriptions towards their own specialty pharmacy or their vertically integrated specialty pharmacy. A lot of these network applications, it's not as simple as just filling out a form. It often includes a very extensive application process, which requires that you accept certain terms for reimbursement, that you have certain patient care and operational standards in place, and that you actually report information back to them as well. So this is an area that is quickly becoming a huge burden and what I would categorize as a large barrier to entry for independent and or other specialty pharmacies, especially health system-based specialty pharmacies. This is an area that we struggle with right now. Specialty pharmacy accreditation. So this is something that I kind of mentioned to you before as well. And unfortunately, this slide is actually outdated too, but I didn't have time to update it. There are now new specialty pharmacy accreditation bodies. So more to come in the future. So specialty pharmacy accreditations are important for a couple of reasons. One is very similar to like the Joint Commission, for instance. They develop a set of standards for hospitals to practice and kind of abide by, and they're meant to make sure that patient safety is of utmost importance and things are managed properly and everything is done well within an organization. Specialty pharmacy accreditations kind of follow along a similar vein where they've developed a set of standards for specialty pharmacies to abide by, and those standards are related to quality improvement, outcomes, performance, and patient management, for instance. So they'll have a set of standards for how you dispense and manage drugs, for how you care for patients, what kind of assessments you've performed, what kind of outcomes you evaluate with patients, and what kind of programs you have in place to ensure that patients have continued access to medications and they're effectively trained, and so on and so forth. So I think you kind of get the gist of it. So that's one reason why the specialty pharmacies are really important. The other reason is more and more frequently, those specialty pharmacy payer networks are requiring specialty pharmacies to become accredited. And some of them actually require not one, but two accreditations. Like our specialty pharmacy at UIC is dual accredited. We have both URAC and ACHC accreditation, and there's a very good chance we're going to work on a third accreditation in the very near future. Manufacturers, interestingly enough, and I'll talk about this in one of the next slides too, they often place restrictions on pharmacies that can dispense their drugs as well. And sometimes when trying to gain access to certain limited distribution drugs, the manufacturers may require that the specialty pharmacies also have certain accreditations or meet certain accreditation standards. So those are just a couple of the reasons why, and it demonstrates minimum competency, that you know what you're doing anyway. If you're developing a specialty pharmacy, whenever I talk to folks that are putting together just in the early stages of developing their health system specialty pharmacy, I always encourage them to start looking at the accreditation process early on, because it kind of provides almost like a roadmap to developing a specialty pharmacy. It talks about everything you need, including like VoIP, like phone calls and stuff. I mean, it gives call center metric recommendations and everything. So pretty much anything you would need to do to open a specialty pharmacy would be outlined in those elements. Problem is, it's pretty expensive. So not everyone has the resources necessarily right off the bat to get accredited, because it does take a lot of time, as you can see here, anywhere from 3 months to a year to work through the accreditation process. And it can also be quite expensive. So just something to keep in mind. Now, the other thing that I mentioned, don't worry, I'm closing into the end here, so I can talk a little bit about myself, is manufacturers often limit, for a variety of reasons, who can dispense their drugs. So open distribution, of course, there's no exclusive arrangements. It goes through any wholesaler, any specialty pharmacy. Managed essentially means that it goes through a specialty wholesaler or specialty supplier. McKesson has a specialty supplier. I think it's Plasma Biologics. Can't remember the exact name. A moderate amount of control would be limited distribution, where the manufacturer may contract with 10 or fewer specialty pharmacies to dispense their product to patients nationwide. So an example of that would be, a lot of the PAH therapies that I work with, Upsummit is a medication that we use very frequently for patients with PAH. There are only about 5 pharmacies nationally that can dispense that drug. So like our pharmacy can't dispense it. And then exclusive would be either a single pharmacy arrangement, or possibly even just 2 specialty pharmacies will dispense and manage their drug. This, I'm also just more for your information. Here's some services provided by specialty pharmacies. If you want a copy of these slides, I'm sure I could send them out to you, Justin. You can feel free to share them. I know this is being recorded anyway, but here's quite a few services that we provide in terms of benefits coordination, clinical and prescriber support, distribution and inventory, and then reporting and regulation. And I've already touched on the large majority of these, but this is just kind of a comprehensive picture. This I just included also for your information. It's some published literature on various specialty pharmacy models. You can peruse at your earliest convenience. So, and then I'll talk just a little bit about my career path and kind of how I got to where I am today. The way I got here was a little happenstance. It's not really what I intended on doing after pharmacy school, but it's an amazing career fit for me. So I graduated from UIC, College of Pharmacy. So I am a UIC grad. I did PGY1 residency at Jesse Brown. Amazing experience. I had an excellent time there. It was hard, don't get me wrong, but it was really great training, working with the vets and working with the program. I actually did stay on there for 2 years. It's kind of interesting because Jesse Brown, their program there is more focused on ambulatory care. delivery models for clinical pharmacy, but I ended up taking an inpatient role there. And I like to kind of joke around, but actually very serious. I kind of took a wrong turn while I was working there. I took an evening supervisor position in the inpatient setting, and it just was not a good fit for me. So I ended up leaving the VA, sadly, but I very coincidentally, and just never really thought I'd end up there, I took a position with CVS Caremark with their specialty pharmacy. And the funny thing is, when I first applied for this role, I had no idea what a specialty pharmacy was. This is not something that we were introduced to in school. I barely even knew what PAH was. I feel like I may have learned about it in my residency, but it was super rare disease, super complicated treatments, and they just don't touch on those things in pharmacy school as much as I would really like. And, it's challenging because they're rare diseases, right? So I ended up taking a position there and realized it was just such a really interesting yet challenging area to work in. I worked there for roughly 3 years. I ended up taking a supervisor role over the clinical portion of the PAH team, or the pulmonary arterial hypertension team. That's where I got my PAH experience. That was probably one of the most challenging roles of my life. It was way harder than residency, to be honest with you. It was super challenging with the on-call program and the critical nature of working with that disease state in terms of the infused prostacyclins and that kind of management. But the training there, I couldn't have paid for that training that I got there, the experience that I got there. In fact, they paid me for it, which is great. So I stayed there for about 3 years, but in all honesty, that's about how long people last there, 2 to 3 years, because with that specific team, you do tend to get burnt out. I wasn't really looking for a position, but I had talked to one of my former mentors from UIC, Joanne Stubbings, and she'd mentioned to me that they were developing a health system-based specialty pharmacy, and she asked me if I was interested in applying for a clinical coordinator role. So I did, and I got it, and I've been here ever since. So I work as a clinical coordinator for specialty pharmacy services, and I'm also a clinical pharmacist for the PAH service. So I still do a lot of PAH, and it's kind of molded, our specialty services in terms of how those patients were managed. So I do a lot of hands-on patient management, which is great. And then I'll just kind of mention too, like, I'm very involved with, every position at UIC requires, you have your job functions, but then you also do a lot of other stuff. So I work a lot with the specialty pharmacy elective. I know some of you are actually in that elective, which is great. So I do that. I work a lot with independent studies students. I take a lot of students on rotation for APPEs and IPPEs. Tons of committee involvement with the college. We do a lot of research as well. In fact, I'm coming up in December. I'm going to start participating with the very first clinical trial that I've ever participated with. So I'm pretty excited about that. Most of the research up to this point has been more limited to survey-based research or retrospective type research. And then, of course, publications, so manuscript and abstract development. And I'm very involved with national organizations as well. In terms of specialty pharmacy, you have to be involved with national organizations. That's really how you get your foot in the door, and you get access to a ton of resources too when you're involved. So just a couple of examples that of orgs I'm involved with. ASHP, I'm part of the specialty advisory group for specialty pharmacy. I'm also very involved with Vizient. I actually chair an outcomes and benchmarking work group for our ambulatory pharmacy development committee. I'm also very involved with AMCP. I'm on the editorial advisory board for their publication, their JMCP publication, and I chair one of the work groups, which looks at helping to improve the quality and the volume of peer reviewers for JMCP. And, it's a lot of work, but it's also a lot of fun. It really keeps your foot in the door with a lot of different opportunities. Now, here is where I will end it. And then I know you guys have classes and stuff to get to, so I want to offer up a little bit of time. But I just wanted to include, a couple reasons why you would want to pursue a career in specialty pharmacy. And obviously, I already talked a lot about this. So growth potential, hands-on care, clinic coordination, there's a lot of career versatility. I have a multifaceted role in specialty pharmacy. A lot of programs now are developing PGY1s in specialty pharmacy and even PGY2s in specialty pharmacy administration. And we already talked about that robust pipeline. So don't forget about it. It's very important. Now, how do you want to get involved, or how can you get involved right now? No matter where you're at in your path, whether you're a P1 or a P4, there's still opportunity to get involved if specialty pharmacy is something you're really interested in. So, of course, work experience is probably one of the best ways to do it, but I know that's not an option for a lot of folks. Volunteer experience as well can also be a really good opportunity to get involved with specialty pharmacies. Taking those elective courses. So we now offer the Introduction to Specialty Pharmacy elective, which is an online elective. It's offered currently in the fall and spring, although I think future is going to be fall and summer, but that's an option. And then we're also going to be in the very near future offering more of an advanced specialty pharmacy elective as well. And then there's a ton of 380, 390 opportunities. If that's something you're interested in, please let me know, because we've got a plethora of projects and research that you can work on in a variety of different areas in specialty pharmacy. This, I'm sure, is drilled into your head, the networking and organization involvement, but I can't stress how important this is, even as a student, to get involved and start developing. Even if you don't network with the right people, just start developing those networking skills. It is so important. I wish it weren't, but it is. And also getting involved with organizations. As I mentioned, I am involved with so many organizations right now. And a lot of them I started with as a student, and I just kind of continue to progress with those organizations. And again, there's also API opportunities in specialty pharmacy. Not just at UIC, but Walgreens has great opportunities. CVS has great opportunity. There's a lot of specialty pharmacy focused APIs that are available. And then, of course, if you're planning on doing a residency and you're super interested in specialty pharmacy, like I mentioned, there are also those opportunities there as well. So I think I talked a little longer than I intended. Sorry, I tend to elaborate quite a bit. But with that, I wanted to open it up to see if anybody has any questions.
And I'll also share the QR codes for the students for their attendance as well. Yeah, if you have any questions, feel free to type them and I can say them, or unmute the mic. Whatever works.
I probably won't come to Chipotle. That's too early for me to eat them.
So they're talking about Chipotle out here. Is it okay if I provide them your email if they do have any questions in the future, maybe?
Yes, absolutely.
Awesome. So I'm sure there's a little bit of stage fright or something. So I'm sure a lot of them, I know a few of the students have a lot of questions, but they're probably thinking about all the rest of your presentation. So,
well, it's an overwhelming amount of information. I realize that, but yeah. So take a minute to digest, and if you have any questions that come up, you reach out.
yeah, thank you for coming. I really appreciate it.
Yeah.
Bye. Hey everyone. So I'll stop the recording. I'll leave this up for you all.
Okay.
I know where the stop the recording is.
Hannah,
Oh man, I'm so sorry.
kind of looks like her.
Yeah.
There it is.